As far as the treatment recommendations, there's quite a huge emphasis on trauma, as far as shaping, having the agencies shape their guidelines and policies with a constant definition of trauma. Where did that come from?
Came from some of the work that we did that showed that in a lot of our communities, we don't have sort of trauma-informed therapy. We don't have all the programs that we need to have. There's just a few places in the state that we really have sort of the deep reserves to be able to do that work. And especially looking at our children, it's the number of our children that have experienced 1 or 2 significant traumas in the state it's mind-numbing. It's really just amazing. And so we want to make sure that especially as we're allocating additional resources, that we're looking at the best treatment that we can provide and making that a priority. So
Does that exclude those without trauma? Because you're specifically wanting, like, the direction towards trauma. You're wanting these recommendations go towards trauma versus maybe someone with a developmental disability or someone with bipolar.
I don't think it was meant to be interpreted that way, that it's supposed to be divisive, but that when we look holistically at what resources should be in a community, that access to trauma-informed therapy should be part of the puzzle. So not that it's supposed to weigh heavier than anything else, but that we don't want it to ever get lost, and that's why you see it repeated a couple of times in this report. I think we don't want it to get lost, that it's an important part of our whole continuum of care that it should be in all of our communities.